almost to the point of giving up surgical pathology. You can see I'm at home. All right. So my name is Vikram Deshpande. I'm a surgical pathologist, Mass General Hospital. I'm primarily a GI pathologist, although I dabble in bone and soft tissue pathology. And so I've invited two very fine soft tissue pathologists, former trainees like me at the Mass General Hospital, Darcy, Kerr, and Nicole. The correct pronunciation, I am told, is Cipriani. Nicole, you want to go first and introduce yourself? When were you at the Mass General? This was like, let me guess, 2012.
Perfetto.
Oh my goodness me.
Grazie, Dr. Deshpande. So yes, I was there between 12 and 13, doing both a head and neck and combined bone and soft tissue pathology fellowship.
And then great. You moved on to, and I forget, where did you do your residency? Was it at Chicago?
It was, yeah. So I did my residency at University of Chicago and then came back there after fellowship to be faculty. So I've been on faculty there since 2013, still doing head and neck and bone and soft tissue with an interest in sort of digital paths. So this is awesome, as well as growth pathology. Things.
I noticed that, yeah. And Darcy, okay, I'm going to guess you started your residency in 2007?
No, not pretty close, 2010. So 2010, okay. So I did residency at Mass General from 2010 to 2013, and then I did 2 fellowships there, the same one that Nicole did, combining bone and soft tissue and head and neck, and also cytopathology. Wow. So now I practice those 3 areas, bone and soft tissue, head and neck, and to a lesser extent, cytopathology at Dartmouth, where I also went to medical school. And prior to being here, I was on faculty at University of Miami for 3 years.
Right, with Andrew, of course, yeah.
That's right.
Oh, I forgot you did cytopathology. I don't think very many people are aware that I'm also a board-certified cytopathologist.
Right.
All right.
Yeah. That way I can see Nicole's facial expressions if she's struggling with a case, or if she thinks it's easy, or if she thinks it's crazy.
You guys got the Excel spreadsheet, right?
Yeah.
Yeah. Okay.
Yeah.
I honestly, like, for full disclosure, I really didn't preview the cases ahead of time.
That's okay.
Naturally. So.
That's perfectly okay.
I looked at them quickly in the 10 minutes before this, so I've seen them super briefly.
All right. So you guys are seeing the right screen?
Yeah.
Yep.
All right. So this is going to be case number 1, and I am not going to give you guys. I'm not going to give you guys any history, right? So as Dr. Nielsen very famously says, it is what it is. It doesn't, and it's all in many cases, right? I don't know whether you guys will agree with me, but in many cases, it doesn't really matter. Mm-hmm. In some cases, perhaps it does. Perhaps, bone versus soft tissue certainly matters. But in most other cases, it doesn't. So what I'm going to try and do is I'm going to give you guys a very brief description of what I'm seeing, and then we can get into the heart of it. So here's the case. You guys can see it, right?
Yeah.
So it seems to be somewhat fragmented. There's some very dense collagenous tissue. I assume this is all non-lesional stuff. I think the lesional stuff is here. And, one of the things that I've been starting to do with my at least my early residents, is asking the question, is there a pattern? And of course, all of these cases are going to be bland-looking spindle cell lesions, which, at least to my eyes, one of the broadest category of tumors, with a range of benign and malignant stuff. And sometimes the benign stuff looks malignant and the malignant stuff looks benign. And so that's the theme. So bland spindle-shaped lesions. So the question is there a pattern here? And do you guys see a pattern that's emerging?
I
don't really.
Yeah, there's vaguely more cellular and less cellular areas, but not very distinctly, and then vaguely bluer and pinker areas, but also not distinct.
Like that, right? Like that looks more pink, and this looks more blue. So not very helpful overall.
Not very helpful overall, but these single sort of enlarged nuclei start to sort of pop out in the background of mixy collagen-y. Yeah.
Yeah, so what does that make you think of, Nicole? What's the first thing that comes to your mind when you see these sort of this is the stuff you're talking about, right? These big,
Yeah.
ugly
Yeah.
cells.
Yeah, I mean, so I think the two things that I think of immediately with those cells that pop out are either like this is some kind of low-grade malignancy with pleomorphism in which I would want to search for mitoses, or some kind of degenerative, kind of ancient type of change in, for example, nerve sheath tumors or whatever that, again, you would want to look for other things like mitosis necrosis to see in which direction you might want to go.
Okay, so I'm going to tell you, I looked hard and I did not find a single mitotic figure. Now, one of the things that I always do is I hate calling something malignant if I don't see a mitotic figure. Does that help you guys? Even on a biopsy, it just makes me so uncomfortable. I'm sure there are biopsies of malignant tumors where you will not see a mitotic figure, but I feel very uncomfortable.
Yeah, absolutely. Unless it's a malignancy that we inherently know that we don't expect there to be very many mitoses,
Right.
like a few specific types, like low-grade fibromyxoid sarcoma or something
Right.
along those lines. But otherwise, yes, and especially when there might be a discrepancy between the way the cells look, like they're in large nature, and the mitotic count, when those two are out of step, then that's particularly disconcerting.
Yeah, I really like that, right? So, I don't know, Darcy, whether you ever saw this paper Ivan and I wrote in Cancer Cytopathology. I think this is now going back 2006, 7. And we sort of described the cytologic appearance of schwannomas. Of course, 100 people have done that before us.
Yeah.
We were definitely not the first. But the comment we made was that, when you see this dramatic pleomorphism without mitotic activity, exactly what you were saying, that's a feature that always makes me think benign.
Yes, I do remember that paper, Vikram, and I like it a lot, and I still bring it up when I'm, sort of looking at FNAs of spindle cell lesions, which frankly we don't get that many of right now.
Right, yeah.
But I have to say my recollection of how that project started, and correct me if I'm wrong, was you wanted to look at many different spindle cell lesions and their cytologic features and see how to tell various of them apart. But then ultimately it was schwannoma that was the distinctive one among many, right?
Correct. And ultimately we decided that we simply can't really tell the other subtypes. Now, I don't know whether that's it's true today or not. But I haven't done very much cytopathology in so long, but I just think it is so hard to distinguish these bland spindle-shaped tumors. And the conclusion I reached was that the only one that I can consistently recognize is a schwannoma. And
Interesting.
we haven't been 100% at that either. So we've gone both ways, calling them malignant and calling them, inappropriately malignant. All right, so back to this case. So clearly there is this pleomorphism and very smudgy nuclei, and I'm actually seeing a lot of background, what I think are intraepithelial lymphocytes. There's one more area, and of course there's this rather myxoid matrix in the background. To me, it doesn't look like, I don't know, just there's maybe there's some cytoplasmic processes and there's some bubbliness to the cytoplasm. It's not helping me a whole lot. There was just one other area that I noticed was this area where there are larger vessels and then there is this sort of pink fibrin on the wall. I don't know whether that sort of tells either of you anything.
Yeah, I think those areas are really helpful when thinking about schwannoma. Usually I find that it's those types of degenerated vessels with either hyalinization or fibrin in the middle, like these ones, that often trigger me to think about schwannoma. And it's interesting to see this area because many of the other vessels that we were seeing in the middle of the lesion didn't have those features. And so it wasn't as striking like many of these in the middle here where you're going to don't look distinctive at all and don't remind me of the vessels of schwannoma. But the one in the upper corner is more characteristic.
Yeah. So I guess we're all coming down on schwannoma, right?
Yeah. I think the other things I would look for once you start, cherry picking these features, I think I start to also then look for is there any suggestion of organization of the nuclei in a palisading fashion, you want a Verrier body. And I think the thing you said before about the smudgy characteristics of the chromatin is also really important in terms of you don't really see nuclear chromatin detail. It just looks schmear, right? And so like a bagel.
Yeah.
Those are the things I look
Did
for.
you say like a bagel? Like smearing on a bagel?
Smear on a bagel.
Right, yeah.
Yep.
You know, the only other thing, I don't know whether you guys find this useful. Now, here the cytoplasm looks, the background looks somewhat different. And I'm seeing these sort of fibrillary processes. I don't know whether this is appropriate, but I always think of these as sort of Schwannian, sort of, I'm sure on EM it's something different, but I always think of this, I almost think felt like a fibrillary background. And there's, again, my cytology hat coming on. And I've seen this in two tumors. I've seen them in GISTs and I've seen them in schwannomas. I don't know whether either of you have used this feature.
I haven't relied on it very much, but I see what you're saying.
Yeah, this sort of stuff. I'm sure there are other tumors. I mean, for one, GISTs do that a lot. You know, if you look at a smear from a GIST, you'll see these long fibrillary processes. You'd see the same thing with perineuriomas as well. So anything else on schwannoma? Schwannomas, I think schwannomas are bread and butter, but there's such a spectrum of schwannomas, and particularly in the frozen section lab, you know. Yeah. God knows, I've made my my errors in my lifetime, more than my share of errors in my lifetime. But any other helpful hints for any sort of trainees out here in terms of diagnosing a schwannoma?
I guess the other thing is that the inflammatory component that we saw some of sometimes can really predominate. You may have fields that are almost entirely lymphocytes or histiocytes, and the lesional cells may be really obscure. Like I remember getting very small cytology type biopsies of a schwannoma that had a lot of cystic degeneration, just a few nuclei of the lesional cells in the background of so many inflammatory cells. And if you just kind of think of it and have material to do a SOX10 or S100, that can help confirm it. But I think the inflammation is pretty characteristic and sometimes can dominate.
Yeah. No, I totally agree with that. And Darcy, I wanted to point out these cells to you. I don't know, do you use those? I'm pretty sure the non-cytopathologists totally ignore these things.
No, teach us non-cytopathologists.
Well, they look like intranuclear pseudo-inclusions. I mean, they're not very well demarcated like you'd see in papillary thyroid carcinoma, but these clearings are very commonly seen in Schwannian tumors. And, you know, it may be an artifact, but it's present enough that it does sort of tip the scale to make one think about it.
Yeah. They almost look like the Lockhern cells of a fat.
You're right. Yeah, yeah, not as well defined. You're right. Yeah. Well, here's one that's very well defined. Right now,
there's a good one.
Talking about an intranuclear inclusion. All right. So. So next. All right. So again, no history, and this is a particularly, to my eye, this is a particularly treacherous tumor. I remember doing this long time ago in the frozen section lab. There was a 0.5 centimeter nodule that one of our surgeons took out from the knee and sent it for frozen, and it looked pretty bland. And I said it's benign. And I remember Andrew came back 2 days later. I was so embarrassed. It turned out to be this tumor. It's not this particular tumor, but every time I see one of these, it reminds me of that story. Anyway, so I think to me, the first thing that strikes me is that it's very blue. And I mean, I guess we all worry when you see a very blue tumor. The other thing that sort of is strange about this is it's not strange, but very pretty about it is, I don't know, there's actually a pattern, right? Where did sorry, I sort of zoomed out too quickly. There is this, here. I don't know, it seems to disappear when I go on high power. Oh, here.
Yeah, we see it.
Yeah.
It's like verrucate,
it's palisading.
Palisading for
sure. Yeah.
So there seems to be some palisading. So that seems to be the most dominant architecture. Maybe there are short fascicles elsewhere, but I'm struck by this sort of palisading, not quite verrucate bodies, but then very blue. And it's blue because there's a lot of nuclear stuff all around. And in fact, there's so much nuclear stuff is that the nuclei are all overlapping. But when I look at this and I sort of put my cytology hat on, the cells don't look particularly malignant, right? In fact, if anything, they look very monotonous. And you could just barely go, if you go solely on cytologic grounds, you could really go down the benign route, but it's just too blue and too crowded. So why don't I open it up and just, Nicole, what's your sort of the first impression when you see something like this?
Yeah. So, I mean, I think the thing that you said about the blandness and the cellular sort of monotony, to me, raised two things. Monotony has always been cited as a thing that's associated with translocation tumors, right? And so whether they be epithelioid or spindle or round cell, I think that's something we always have to think about. The pure cellularity of it and the blandness of it certainly should make you think, aside from like you said, aside from a benign cellular lesion, some kind of monotonous malignant lesion, like a synovial sarcoma, or some other sort of, low grade, but, not that synovial sarcoma is necessarily low grade, but some other, cellular sarcoma that has some vague organizational structure to it that's not really diagnostic, but that at least you can sort of see these bands or fascicles. So I think when you think about synovial sarcoma, I always think to lump it together with something like an MPNST, or like, I guess technically if you're in an infant, like a fibrosarcoma type of thing, or in an adult, fibrosarcoma / DFSP. Now we're getting like, way. I've even had Ewing sarcomas that mimic synovial that are very spindle, similar to this, but the sort of minimal, at least so far, the minimal mitoses is also a sign of maybe something not extraordinarily high grade.
Yeah. No, that's that's where my mind would go. Darcy, you have anything to add in terms of a differential diagnosis? Think of just imagine you're a first year resident and you're trying to give them as broad a differential diagnosis as possible.
Yeah, that's a good process. I think I'm right there with you in terms of the monotony being a clue to different things that it could be. I would think about solitary fibrous tumor as another cellular benign thing, although we don't have the characteristic vascular pattern. We've just seen a schwannoma. It's not quite like that, but could this be a cellular schwannoma because of the palisading? The gist, because of the palisading and kind of the packed cellularity of it, would be kind of some other things that I would be thinking. But I am struck by the fact that we haven't seen any mitoses unless I've missed them. It does seem like something based on how cellular it is. There should be some, but I haven't been seeing them.
And I know you alluded to this, but what do you make of this palisading? Because it's just so striking.
Yeah.
I guess
just schwannoma.
I've seen it in smooth muscle tumors too.
Good point. Yeah.
Could this be a smooth muscle tumor?
I feel it's too blue. The nuclei are too overlapping. I feel like for smooth muscle tumors, when I'm looking at them at low power, the most striking thing is a pink appearance and a more well-developed fascicular architecture. Now, could it be a poorly differentiated smooth muscle tumor? Then it's too uniform and it's not mitotic enough, so it doesn't really fit for me for that.
Yeah.
The only place I've seen very odd morphology smooth muscle tumors is when people in GYN sort of show me things.
Oh, yeah, because everything is a smooth muscle tumor until proven otherwise,
Correct. Right. So I guess we are going out. I think we would all favor a sort of a malignant process, right, over a benign process. And this clearly needs to be worked up. This was positive for EMA, keratin. And then we at least do I do both FISH because it comes out a little sooner. And this had the characteristic translocation for synovial sarcoma as well as the fusion. We do the Archer assay. Do you guys, what do you guys do for molecular testing?
We have our in-house, both like sort of DNA point mutation sequencing and an RNA-seq. So this would come out in the RNA-seq. If like you, we want an answer quickly, we can send out for FISH. We don't really have a lot of FISH probes in-house, but most of our answers come in the sequencing.
Yeah, our current panel actually doesn't cover synovial sarcoma. We have only kind of some select RNA-based fusions that we do cover, and in the process of expanding the panel. So when I've confirmed synovial sarcoma, I've sent out either for FISH or for Archer at a different institution, or the Mayo Clinic SARC-P panel we've used is pretty broad coverage.
What do you guys think of that new antibody? Do you have access to it?
We don't have it.
Oh.
We don't have it either, but everyone who has it seems to say it works quite well.
Yeah.
What is your experience?
Oh, it works.
Ben?
This is the what's it? The SS18 antibody.
No.
Or there's an antibody against the fusion transcript as well, correct? I think.
Yeah, there's two, right? And Brigham has both. And now that you're merging, you'll probably have better access to it. But
no, I think we did get the SS18, the IHC, and it works wonderfully. I've completely given up on TLE1, which never really worked in my hands.
It's useless. Stains everything.
Really, I still use it to
Really?
at least help exclude synovial sarcoma, because if
Oh,
it's
that's a good
TLE1
point.
negative, then I'm going to say this is unlikely. You know, sometimes people are trying to think, broadly, could this be synovial sarcoma? And then negativity for TLE1 and something that I really didn't maybe think would be an argument against it.
Yeah, that's a good point.
Fair
But
enough.
positivity, yeah, big pitfall. Things like schwannoma are positive. So many things are positive.
Yeah, yeah. So that was a synovial sarcoma, guys. That was lovely.
Beautiful.
That was the thing that I missed in the knee joint, and I was most embarrassed about. And I think the problem with synovial sarcomas, I've learned over the years, is that they are often mistaken for schwannomas clinically. They turn out to be small little lumps and bumps, quite unexpected, and they look so bland that I think unless you have it on the top of your head, you're going to at some point go down the tubes on a synovial sarcoma. And one of the things I always do is throw a keratin. I always throw immunos at any things that look any remotely sort of bad. So, if you throw a keratin and an EMA at it and you see any reactivity, it's sort of worth thinking about it.
Yeah.
Vikram, how would you grade that synovial sarcoma?
Grade 2.
No grade. No grade.
Do you ever make a diagnosis of grade 1 synovial sarcoma?
No, we don't. No. I must admit I'm not. See, this is where my deficiencies in my knowledge show up. I'm not up to date on the grading systems, but I do.
It's a good question. I mean, I think there's an argument that the poorly differentiated ones, and those would do worse, and that offers a distinction. But yeah, in terms of
binary, right?
Binary, yeah.
A regular or synovial sarcoma.
Regular or bad, yeah.
Or bad.
And I know, coming back to poorly differentiated synovial sarcomas, we have some differences of opinion with our sister institution across the street, across the river. And, I think, there is some level of disagreement as to what constitutes a poorly differentiated synovial sarcoma. Anyway, I think in the interest of time, I'm going to move on. This is case 3, and this is very well circumscribed, right? I think you almost want a feeling that there's a crack here. Is it in a vessel? Maybe not. So well circumscribed. Again, it's on theme because it's very bland and it's spindle-shaped cells. Again, interestingly, in a sort of a myxoid matrix or a background, and there are some, I don't know, I just talked about that fibrillary processes, and now I'm actually starting to see a bit of fibrillarity. No rule is 100%, right?
Wispy. Let's call it wispy.
Wispy, okay, to distinguish it from fibrillary. And, there's this reactive-looking fibroblast. I'm pretty sure that, I can promise you there was a little bit of mitotic activity, but very well circumscribed. I mean, obviously, malignant tumors can be well circumscribed as well. I certainly have seen some examples of that.
And benign tumors can be infiltrated.
Infiltrative. What's a classic benign tumor that's infiltrative?
Fibromyxoid.
Oh, yeah. Well, if you consider it benign.
Right, locally aggressive.
Locally aggressive, yeah.
Nodular fasciitis, yeah.
Yeah, nodular fasciitis can be pretty infiltrative, yeah. Okay, anyway, so Darcy, you want to give it a go as terms of, what your thinking might be when you see something like this?
Yeah. I mean, I think the combination of different patterns and elements that we've seen would call to mind something like nodular fasciitis, although it is odd that it's well circumscribed. There could be an intravascular nodular fasciitis, which would be in the differential.
Yeah.
Otherwise, something like a fibroma of tendon sheath, which can have maybe some relationship to nodular fasciitis in the sense that this is well circumscribed. So, I mean, it looks fibroblastic, myofibroblastic. Those would sort of be kind of the leading differentials.
Do you see a pattern? Does it help? I mean, I'm sort of seeing a storiform pattern. I don't know whether this sort of helps you or hinders you, or does the pattern help you in any way in this case? I mean, much of this is patternless, but then there are areas that you could sort of start seeing this vague storiform pattern.
I think it would help in supporting something like nodular fasciitis and arguing against something like fibromatosis. If we were thinking of fibromatosis, it's not fascicular enough.
Right.
And those small kind of microcystic, almost myxoidy-like areas.
Like that,
Yeah, I think are good for that. And yeah, the nuclei not, being characteristic. I mean, when you think about myofibroblast nuclei, like I think that oval shape with the little tiny nucleoli, I think really, if people, training start to really investigate the nuclear features, I think they'll start to appreciate those.
In myofibroblasts in general. Yeah. Because you see the same thing in fibromatosis, right? I mean, but as you said, fibromatosis, the fascicles tend to be much, much longer. I mean, all three of us know that this is nodular fasciitis. And the trouble I have is in trying to explain to a first-year resident why I think this is nodular fasciitis and not something like this. And it is because it is, right?
It's like pornography. You know it when you see it.
You know it when you see it,
But I'm afraid I can't use that explanation.
You can cut that out.
I can't use that with a 6-year-old. So
Aunt Minnie, right? It's like your Aunt Minnie. You know her when you see her. That's.
But what is it here? I always struggle. What is it here? People talk of this tissue culture appearance. I'm not sure whether that helps me. So. Is there anything that we can sort of give people in
it's sort of like the constellation, right? The type of cells that Nicole was saying, the storiform architecture, extravasated red blood cells, the mucin pools, the sort of constellation of features all together. I guess the only other thing...
Sometimes keloid-like collagen.
Keloid-like collagen, which we don't really see here, but is helpful when it's there. An IMT, right? One of the patterns of IMT kind of has this myxoid granulation tissue-like appearance. That would be something to consider, although we were just saying that it's exactly nodular fasciitis, but...
Yeah, no, that's fantastic. Thank you.
And you mentioned mitoses. I mean, we sort of have to remember that these things are rapidly growing and can be mitotically active, so that can be a pitfall, right? Especially if it's infiltrative. But making sure that there's no morphologically atypical mitoses, but allowing mitotic activity to some extent.
Would you do any immunohistochemistry on this, or would you just sign it out?
I would want to check the clinical history just to make sure it kind of fit in a location, although it can happen everywhere, but maybe head and neck or somewhere where it's typical and maybe fast-growing, maybe a younger patient. Those things would kind of reassure me, but provided things seem to fit clinically, I feel comfortable probably doing it on just morphology. I think immuno is not that helpful. There's nothing in our differential. Well, I guess if I said IMT, maybe if that was a differential, you could throw an elk or a Ross, but in general, it wouldn't be that helpful.
Yeah, but I mean, we send for fish for USP6 if it's on the verge of being uncertain.
Yep. Same.
Yeah.
Which I think is really helpful.
Do you remember if you confirmed it, Vikram, for that case?
I don't believe so. No. I mean, I think in many cases it's so obvious that one doesn't bother.
I think at some point, well, I guess we're not really doing bone today.
Yeah.
But at some point it's important to sort of consider how to process tissues for, potential molecular studies. Because I think some smaller hospitals out there maybe over-decalcify things that shouldn't be, and then that option is lost. So.
Yeah, we use EDTA, and so that works quite well.
Yeah.
All right. So next tumor, again, I actually have no idea where this is. What this is
Bone.
this
It looks like bone, yep.
it may be in the bone, right? I don't know whether this was in the bone or whether this was sort of periosteal
Yeah.
invasion or periosteal reaction. Let's just get this out of the way. You know, this is not an osteosarcoma. Let's not go into that discussion, which could be another story altogether. So very bloody, again very monotonous. Maybe, well, sort of spindled, right? It's not your perfect spindle cells. It does look a little plump occasionally. Almost rounded in areas. Gosh, now there is actually mitotic activity. You guys agree?
It's more mitoses than we've seen in all the other cases combined.
I know. Is there a pattern to it? No, but there's these big blood lakes. You know, blood lakes always make me think of a metastatic renal cell carcinoma, but this isn't that. There are some big dilated vascular channels, not quite Staghorn, but you know, a little bit like that. I guess this is a much more challenging case, right? I mean, it's not very clear what it is, at least. This looks a little blander. Again, very monotonous cells. Fairly bland, right, cytologically. Maybe a little matrix, sort of bluish matrix in the background. Anything that sort of jumps out at you when you see something like this? I mean, it is a mesenchymal tumor. Let's just take that for granted. Let's assume that this is a soft tissue tumor. Is there anything that sort of would, Nicole, jump out at you and sort of in terms of a potential differential? I'm sorry. Oh, there is something interesting going on here. I'm sorry.
I mean, I think this is really tough because it could raise so many possibilities, ranging from those low power blood lakes for like an angiomatoid fibrous histiocytoma to these, you know, quote unquote staghorn dilated branching thin walled blood vessels for like an SFP or like a, you know, in the right location, a hemangioparasitoma. I think all of those things.
Before you go on, you know, I remember we used to call everything hemangioparasitomas, right? And now the term hemangioparasitoma is restricted to the head and neck, correct?
Yeah.
So Nicole, can you tell me exactly what changed and how it changed?
I would be happy to. So pretty much HPCs, hemangioparasitomas of brain, and other sites basically were all shown to be morphologically, immunohistochemically, and molecularly solitary fibrous tumors with, you know, CD34 positivity, NAB-STAT rearrangements. And the only thing that came out of that was not that were the quote-unquote glomangioparasitomas in the sinonasal cavity that are really, truly perivascular myeloid neoplasms, glomus, right, glomoid. And so they stain for myeloid markers, SMA, beta-catenin mutations. And so they persist in the sinonasal cavities, but pretty much, quote-unquote, HPCs elsewhere are solitary fibrous tumors. Brain, pleura, soft tissue. Do you agree, Darcy?
I do agree with that. Yeah. I think the part that becomes confusing even to a greater extent is all of the other potential.
Sorry, Darcy, we got cut off, right? I forget what were you saying.
Well, we were starting to we're starting to talk about the confusing nomenclature and then other tumors which might actually be kind of pericytic in nature or, maybe related to myofibroma, myoparasitoma spectrum of tumors that are sort of that perivascular myeloid entity that's not SFT, that's also not the sinonasal thing, but it becomes sort of confusing to sort some of those out.
Yeah. You know, just in the interest of time, I'll tell you that this was actually a solitary fibrous tumor. You know, I think it is complicated. I think, you know, just in terms of a differential, I don't know. Let me just throw a few things out there. Maybe I'd think of a synovial sarcoma. I could potentially think of, It does look very monotonous, so it has to be one of these. It's very likely to be one of these translocation-associated sarcomas.
Yeah.
Anything else in the soft tissue you would think of, just very broadly off the top of your head in terms of a differential?
Oh, I was just going to say, if your clinical team asks you, is this benign or malignant, what do you say?
Oh, I mean, I'd like to hear your thoughts.
I say all solitary fibrous tumors are potentially malignant, but we kind of take into consideration many features, right, including cellularity, mitosis, necrosis, size, et cetera, to sort of assign a risk stratification to these people, right? So
yeah.
I really hate calling them benign or malignant outright, because we don't really know.
Yeah, definitely. We usually do the like D'Amico-based risk assessment and sort of put that on the report for the associating the risk. But I guess it's interesting because the case that you showed had so many mitoses that probably in the old sort of binary way of thinking things that would have been considered malignant straight up just based on mitotic activity, although we can question, is that the best approach for it. I guess the only ones that I would still kind of frankly call malignant is the rare dedifferentiated case that I've seen that's actually just a high-grade sarcoma in association with a solitary fibrous tumor.
Yeah, for sure. I just wanted to say that Liz D'Amico was a former resident at Mass General Hospital. Did you overlap with her? Darcy, you may have.
I didn't, but I heard a lot of people talk about her, and I subsequently have met her and worked with, sort of seen her in different things. And
yeah. She's a terrific pathologist. Mm-hmm. And this was, just for completion, was strongly positive for STAT6. Which, again, is a fairly good stain. And most of these are CD34 positive as well. Yeah, so fairly well circumscribed tumor. In fact, very well circumscribed, beautifully inked. I hate ink, I don't know what your feelings are about inking, but God, I mean, ink flows all over the place. And in many cases, it's so difficult to assess margins. I mean, inking is supposed to be the panacea for everything, but I just sometimes think it causes more trouble than good.
Sometimes it does, yeah.
Black is the best and lots of vinegar. Other than that,
that's very helpful. So to quote you, black is best and lots of vinegar. All right. So very low power appearance, and what I'm actually seeing is sort of these pale areas and these very pink areas, and it's quite prominent under very low power. There is some value to low power, isn't it? I mean, I think the instinct of a first year or an early trainee is to go right away into low power, but low
you mean high power,
high power,
right?
I'm sorry.
Exactly.
Yeah. And so then this rather looks very fibrous but incredibly bland, isn't it? Oh my God. I mean, I would be hard-pressed based on the cytology to call this malignant, and a lot of collagen. In fact, the collagen between the cells reminds me of fibromyxosis. And then there are these sort of more myxoid areas, and I know both of my soft tissue pathologists on this call know precisely what it is. But again, this tumor comes with an interesting history. I know of cases at Mass General where this particular tumor was called fibromyxosis, and then was reclassified after that paper by Evans. And it was reclassified when it metastasized to the lungs. So, anyway, yeah, Darcy, you want to give it a shot? You want to give people a sense of how to avoid that trap.
Yeah, well, I think exactly as you're saying, it's very, very well circumscribed, which should be sort of a tip-off that it's not fibromatosis, because usually fibromatosis is so infiltrative. But like you said, it's so hypocellular and bland, but we do have this appearance at low power that there's an alternation of very pink areas and slightly paler areas, which definitely can make us think about low-grade fibromyxoid sarcoma. And you start to see that in some areas there's a little increased cellularity, like maybe around some of those little kind of curvilinear vessels towards the bottom. That might also be a clue. But as you said, incredibly cytologically bland. So it's no wonder that these were called benign. Certainly you could think about some type of fibrous tumor that's benign? Like
I think fibromatosis was most commonly, that was a tumor that was most commonly, you couldn't really call it a misdiagnosis because we just weren't aware of that tumor at that point. So
exactly.
It's always fun going back on your old cases. I've gone back on. I've been at Mass General long enough now that I can go back, and I pulled out a gallbladder carcinoma the other day, and it was a horrific sign out. I essentially said nothing. I said this could be benign, this could be malignant, and then I looked at it the other day and said it is so obviously malignant. I mean, what was I thinking? But yeah, so. Darcy, I mean, I always get confused between low-grade fibromyxoid sarcoma and myxofibrosarcoma. How do you put them straight in your head?
I like the very simple rule of thumb that low-grade fibromyxoid sarcoma is more pink. It leads with the fiber. The fiber is more pink. Yeah. Fibromyxoid sarcoma at low power is pink. Myxofibrosarcoma kind of leads with the myxo. At low power, it's going to be very pale and myxoid, and that usually holds up pretty well. So that would be the low power appearance. And then, of course, at high power, myxofibrosarcoma is going to have some atypia, even the low-grade ones, whereas here we're very impressed by the bland nature of it, and that kind of takes us back to our discussion about a translocation-associated tumor, which we now know that this is.
And if you're asking about patient, characteristics, I think age is a really important one for that distinction, right? With younger people being low-grade fibromyxoid and older people being myxofibro in general.
And depth, right? Depth, these tumors are usually deeper. Myxofibrosarcoma is usually going to be more superficial.
Right. Yeah. And a lot more infiltrative as well. Was there anything else in the differential that we should potentially consider? I mean, this is so obvious because of this sort of myxoid and fibrous areas being sort of distributed across the entire tumor, but I guess
maybe like a desmoplastic fibroblastoma, i.e. collagenous fibroma. I mean, it's probably pretty big for that, but
yeah, that's a good one. Yeah, and we do have some excellent immunohistochemistry, right? MUC4. Are there other tumor types that are MUC4 positive? I can't remember. This tumor, of course, is strongly MUC4 positive, but
its high grade counterpart, sclerosing epithelioid
fibrosarcoma. But have you guys seen other tumor types? I think the reason I asked that question is because I use MUC4 exclusively when I'm thinking of a low-grade fibromyxoid sarcoma, and I don't really use it as a part of my panel outside that, so I really don't know how specific the stain is.
I once saw an ossifying fibromyxoid tumor that was positive for MUC4, but it's not really a very common differential. Again, like you said, that you would only use it when you're thinking about it.
Yeah.
And then, of course, I'm sure you probably use it in maybe GI for different types of like epithelial cells. That's out of my wheelhouse, but I mean...
I am not a fan of the mucks.
They're mucky. They're murky.
There are some people who muck this, muck that, and muck the other thing, but I am an anti-mucker. All right. Anything else we talk about? Obviously there's a translocation.
Us with one of the Krebs3, Krebs3L1 or 2.
Yeah.
Rarely EWSR1, but usually FUS.
Wow, Darcy, I'm impressed. You can spin these off the top of your head.
No.
I think anything else, Nicole? Any last words of wisdom before we finish up?
I think those words were brilliant.
No, I mean in terms of dealing with a bland-looking spindle cell neoplasm. I'll start with mine. When you see a bland spindle cell neoplasm, do not forget to think about a synovial sarcoma. That's my words of wisdom. Do you guys have any?
I think I can add. Always think about some kind of nerve sheath tumor and some kind of sort of fibroblastic, myofibroblastic thing as sort of groundwork for how you frame things and when you consider staining.
In talking about immunos, what do you have a basic panel of immunos that you'd use and sort of when you encounter one of these? Obviously, it's going to change with every tumor type, but sort of broadly, what do you start with typically?
Yeah, so I mean, I think for nerve sheath types of tumors, some kind of S100 or SOX10, for some kind of fibroblastic, myofibroblastic, I use SMA, but I know that some people can also use like a Desmond. You know, and then from there it'll sort of depend, right? If like you're saying, if you want to think about an LGFMS or a synovial, you might want to do an EMA, and if you're thinking about something else, then it'll diverge from there. But sort of my basic markers are sort of those. Darcy?
Yeah, no, very similar. I think I probably include either a keratin or EMA up front on many to begin with.
Do you prefer a type of keratin?
Yeah, in my lab currently, the cytokeratin MNF116 just seems to work the best. And in other labs I've been, the AE1, AE3 was better, but just in sort of having developed the experience here, it stains most of the things I want it to stain. Sometimes it overstains, so I do have to be careful with that, but it's a very good broad spectrum keratin, especially for things like sarcomatoid carcinomas. It's very good.
Yeah.
Okay.
We've had pitfalls. I'll just reverse for 2 seconds with the you know, overlap melanocytic nerve sheath markers, where a, you know, high grade, not so much low grade things unless it's a desmoplastic melanoma, right? But certainly S100 and SOX10 can be overlapping in nerve sheath and melanocytic lesions, and sometimes that can be really, really hard to sort out without other molecular findings or clinical history.
All right, I guess we'll stop there. Thank you guys. This was so much fun.